All right, so any questions from material we hit last time? We were talking about the cardiac cycle. We were talking about electrolytes and how they're flowing in and out of the cell to cause their action potentials. Everyone remember that, right? So for instance, when we're looking at those fast response cells, again, which are not pacemaker cells, they have a rapid increase in electric potential is due to influx of what ion? Sodium, right? Remember this, we talked about sodium as being a big cause for that big upswing there and that electric potential there. So the first group we're talking about today is the sodium channel blockers. And if you remember, these are class 1 drugs. As far as antiarrhythmics go, we have 1A, B, and C. You're going to see they have a little different activity from one another, and that changes how they're going to be used clinically, as we'll see. The first group we're going to look at is a class 1A. Basically, and if you can see here on this picture, you can see how the action potential will change. Notice by blocking that sodium influx, you're going to be decreasing kind of the total positive potential that cell is going to develop, but you're also going to be elongating this whole process here. And again, when we said when we elongate the action potential, what does that do for us? It changes the refractory periods. Remember, those refractory periods are very important. You have absolute and relative refractory periods. Absolute just means what? Nothing can stimulate it to have another action potential. And by elongating that, by making that longer, you make it harder to have one of those range arrhythmias develop there, right? So that's the big point here. Notice here the class 1A, these are going to be good for both atrial-derived arrhythmias and ventricular, so you can kind of use them for either one potentially. Just know the 1A is going to have a little bit more affinity for the open channels, right? So again, as soon as that action potential comes along and triggers that cell, that open channel will then be affected by these drugs here, okay? Pretty slow dissociating. That's why you're going to see this nice prolonging effect on the action potential. We have 3 drugs in this group. PDQ is how I remember that. So I'm going to have procainamide, quinidine, and disopyramide. First one is going to be quinidine. Does anyone know what this is chemically related to? Actually, I have it on the slide. It's actually quinine, right? Quinine is kind of an old school anti-malarial sort of drug. It actually comes from a tree, the cinchona tree, and it's, again, it's nice to point out kind of natural sources for some of these medicinal products. Does anyone know, if, say, for instance, you guys wouldn't do this, but if you had a patient who's going out for, drinks on the town and they order a certain cocktail, which one of these would actually contain some amount of quinine in it? No, it's actually a gin and tonic. Tonic water actually contains quinine, and that's actually the thing that makes it glow underneath black lights. So if you ever see that, not you would see that, but if you had a patient who was seeing that outside of the bars, that is actually what's going on there. Tonic water has quinine in it. This is actually structure related to this quinidine. Anyway, a little bit of pharmacy trivia. So this drug is going to help to slow that conduction, prolong that refractory period. It's going to be good for both the atrial and ventricular arrhythmias. There's going to be some additional effects here as well. So for one, it's going to act as an anticholinergic. So what do you think that's going to do to heart rate? It's going to speed it up, right? Because normally you expect acetylcholine on the muscarinic receptors to slow down the heart rate. This is going to have the opposite effect here. It also can act as an alpha blocker at higher doses. What do you think that's going to do? Block alpha receptors. It's going to vasodilate and cause hypotension potentially, right? So again, there's going to be some of these ancillary effects. And again, not only does any of these antiarrhythmics cause arrhythmias, but they can also have their own kind of litany of side effects they can cause. But some indications where you might see this being used, we can maintain rhythm with, say, atrial fibrillation or atrial flutter. Now, when I say maintain the rhythm, that's called rhythm control. There's also going to be what we call rate control. Anyone know the difference between the two?
We are just slowing down the rate, and rhythm, you're controlling the rhythm from A to omega.
Yeah, so basically, essentially when you have rhythm control, you're trying to keep the heart in a normal sinus rhythm, okay? You're trying to keep it from going into AFib or A-flutter, right? That's rhythm control. Rate control just means the atria can be in AFib or A-flutter, but you're trying to slow down that conduction from the atria to the ventricles, right? So you're slowing down the automaticity, so that way if you have the atria that are going at, say, 200 beats a minute, you don't have 200 beats that are getting transmitted to the ventricles. If it's going that fast, it can't really operate effectively as a pump, right? So you're slowing down, so you're going to find that there's either the rate control, which we'll talk about a few classes of drugs that are going to do that here, and then there's the rhythm control. The class 1 antiarrhythmics are going to be a form of rhythm control to try to keep that patient in normal sinus rhythm, okay? That's kind of the big difference there. You can also use this for things like VTAC. And when you talk about conversion of someone from an arrhythmia into a normal sinus rhythm, anyone know what you call that? Cardioversion, right? So again, there's 2 types of cardioversion. There's chemical and there's electrical cardioversion. This is a form of chemical cardioversion. You give them drugs in order to convert them back to normal sinus rhythm. How do you do it with electricity? Shock them, right? So again, that's the other way to do it. So depending on the stability of the patient, if they're unstable, typically more reliant on electricity versus if they're in a stable, kind of normal, they're perfusing well. This is the cases where chemical cardioversion can be more useful, right? Other things to consider. This acts as a CYP2D6 inhibitor, right? We don't talk about CYP2D6 often, but this can affect things like morphine, right? This can affect drugs like codeine that have to be converted over codeine into morphine, so that can cause effects where maybe your drug's not working as well as it used to, right? So little things to consider. Now the toxicity here is pretty unique. We call, when you have someone who's toxic from quinidine, synchonism. You can see that term here, synchonism right here. It's kind of this triad, and if you ever get pimped on this, is a good one to know. It's going to cause tinnitus, dizziness, and blurred vision. And a lot of it comes through with these ancillary side effects. You're going to see that not only is it working as an antiarrhythmic, but some of these other factors as well. So again, you can see a lot of nausea, vomiting, diarrhea. You can see these arrhythmias that can develop from this, hypotension, as we mentioned, due to the alpha blocking effects there. Some rare thrombocytopenia, which can be fatal for your patients. You can even have things like torsades that can develop there. Now, again, when you see torsades, what is the cause for torsades? Prolonged QTC. So why do you think this would cause prolonged QTC? Remember, we're prolonging the whole action potential, right? So again, yeah, you're certainly going to see things like the PR interval is going to get longer, but the QTC is also going to elongate as well. This affects the entire action potential there. We're going to look at some drugs later on that primarily affect that repolarization phase by affecting potassium, but when you're starting off by affecting the sodium, you're going to affect the entire action potential. QTC is going to get prolonged as well, okay? And again, when you say this quinidine sudden death, what do you think that's caused by? An arrhythmia. So usually ventricular arrhythmia can occur here. So again, these are why these drugs are so dangerous. We don't use them as often. I will tell you that more frequently we're going to use more cases of rate control than we are rhythm control, because there are cases where patients will be on it, they'll be fine for a while, and then all of a sudden something will happen, they go into an arrhythmia and die. Okay, could be due to electrolyte changes, could be changing in the electrophysiology of the heart as time goes on, could be a lot of features here. But we still use these occasionally, so it's good to bring them up and talk about them here. Okay, the next one here is going to be called procainamide. This one I do see used occasionally still, like with our cardiac kids. Occasionally we'll have kids that are on procainamide. This one's nice because it has less anticholinergic activity. You're going to see less effects on things like the vision, less effects on causing tachycardia, things like that. However, this one is unique and it is similar in metabolism to a drug we talked about before called hydralazine. Anyone remember what we used hydralazine before or for? Used for hypertension, it's a vasodilator, right? Remember what we talked about with the metabolism of that drug? Yes, the same thing happens to your procainamide. So if you have a slow acetylator, their levels of the drug are going to do what? They're going to increase, right? And that's where you can see those kind of immunologic reactions like this lupus-like rash and things like that. Fast acetylators, on the other hand, you're going to do what? You're going to clear the drug really quickly, and the drug may not be as effective, right? However, when you're using something like this, usually you're doing it via continuous infusions. That way you kind of titrate your dose based on effect, essentially. So you're going to see this more like on the inpatient side of things more often than not. Also has this active metabolite called NAPA, which actually has some class 3 activity. We'll talk about class 3 drugs a little bit later, but again, that just kind of makes it so that you can use it for a few different types of arrhythmias and just affects potassium channels, not only just the sodium. Again, you can see things like hypotension, slowing of conduction, so again, you could see bradycardia due to this. And the big thing to note here is that lupus-like syndrome. As I mentioned, again, that's going to be in slow acetylating patients. Again, can you really predict who's going to be slow acetylator? Not reliably, so it's one of those things where you're just going to have to try it and see how the patient responds to it. And then torsades, again, is another risk because, again, we're extending that action potential, so that's going to be the same for any of these class 1A antiarrhythmics. Now, the last one I have here is going to be disopyramide. These effects are very similar to quinidine, has even more anticholinergic effects, so again, more sort of side effects related to the anticholinergic activities here. And again, cases we're going to use include VTAC, supraventricular arrhythmias. Again, this will help to keep patients in a normal sinus rhythm, hopefully, especially like AFib, A-flutter, etc. Again, very similar toxicity as you would see with something like quinidine. You don't get that same synchonism you see with that. You don't have like the tinnitus and the blurry vision and dizziness, but certainly you're going to see the antimuscarinic effects. Do you guys remember the mnemonic we used to remember antimuscarinic activity? Blind as a bat, hot as Hades, dry as a bone, red as a beet, mad as a hatter, right? So again, remember those are being the effects of the drugs here. So again, if I were to give you a test question and I said, hey, this patient comes in, they're on an antiarrhythmic, they're coming to you in the ED, and they're on this antiarrhythmic, and they're having these sort of side effects, and you don't have any medical records to go off of, how can you figure out maybe which drug it is, or which one is most likely is? Those are things you can do, right? Because again, you think, I always have all the information, I know exactly what my patients are on. Is that always the case, though? Very frequently, it could be not, right? So especially if patients come in altered and they're not able to communicate with you have no information on them, you may not know specifically what they're on. So be careful with that. Okay. So moving into the 1Bs now, you're going to see this has a little different activity here. Basically, the big thing they're going to do is focusing on shortening phase 3. They can also help with decreasing this ectopic foci automaticity. When I say ectopic foci, what does that mean? Yeah, basically some other part of the heart is acting sort of as a pacemaker when it is doing so inappropriately, right? And so what's interesting here is that this actually has higher affinity in cases where you have ischemic tissue. Now, when's the case you might have ischemic tissue in the heart? During an MI, right? So again, this is going to be a case where you're going to see this drug being used more frequently, the 1Bs, used in the case of MI, than you might see it used in other instances here. Again, pretty rapid dissociation, but the big thing here is going to focus on ischemic tissue, and it helps reduce that ectopic activity, okay? The one drug we're going to talk about with this is going to be lidocaine. Now, normally when you think of lidocaine, you think about it being used as what? For numbing, as an anesthetic agent, called a local anesthetic. Does anyone know how it causes local anesthesia? Blocks sodium channels, just like it does in the heart. It does the same thing for the nerves that are conducting pain signals up to the brain, right? Again, all these action potentials are roughly the same, right? Sodium influx is the big thing that causes that increase in potential. So if I can block sodium channels locally, say if I have a laceration, I don't have those pain signals being sent up to the brain, right? We'll talk about these drugs later on and from a local anesthetic standpoint, but right now let's focus on the cardiac effects. Here, you can see lidocaine being used, especially in cases where you have acute MI. Now, I will tell you that lidocaine is being used less frequently now. We have another antiarrhythmic we'll talk about later on that's kind of taking the center stage in a lot of cases. But again, you still may say it being used as a backup agent in case other ones fail. But VTAC, VFib, some cases may use it for Wolff Parkinson White. So again, a couple of different indications here, but lidocaine, mainly you're thinking about it used in cases of infarction, right, or ischemia. Now, lidocaine, this has to be given via IV. This is not something you can take orally because it will get destroyed in the GI tract. And so you're going to find that by working on that ischemic tissue, it's going to hopefully help to have less effect on normal tissue, so you kind of get things back to normal, right? This is not going to be effective against atrial arrhythmias, however. So if I were to ask you which one of the, class 1 antiarrhythmics is not going to be good for atrial arrhythmias, not that I would ask you as a negative question, but let's just say, for instance, I ask you a bad question, you would say, okay, well, I know lidocaine is not going to be good for an atrial arrhythmia, okay? Now, toxicity is really important here because you do have to watch out for patients who cannot metabolize it very well. CNS toxicity is a big thing, right? Especially if you have patients who cannot metabolize the drug very well. So, say, for instance, you have someone with hepatic impairment, you may have to decrease your dose pretty significantly. And in fact, we'll have recommendations, if they have hepatic impairment, drop your dose by 50% because they just cannot clear it very well. And so this can lead to things like drowsiness, confusion. You can see seizures that can develop here, so to be really careful with those. And then obviously, what's the other big toxicity you expect to see with any antiarrhythmic? Cardiac toxicity. So again, those arrhythmias are going to be a big deal as well. And in fact, that's one of the big things you always want to think about when you're dealing with local anesthetics is that cardiac toxicity is going to be a big deal. CNS toxicity is the other one. Okay. Again, this is going to be more important, especially if you're working in surgery where you're dealing with a lot of these local anesthetics. If you're dealing with ropivacaine, bupivacaine, all these things, they can be fatal if given intravenously on accident. This is a case where we actually want to do this intravenously because we want it to have effects on the heart. Okay. So again, we'll talk about those a little bit later on in the surgery section next semester. Okay, the 1Cs, this is the last group of the class 1 antiarrhythmics here. These, again, are going to work pretty similarly to the 1As. Again, they have high affinity for those open channels, but they dissociate even slower than the 1As. Okay, we only have 2 drugs that fit into this category here, but you can kind of think of their actions as pretty similar to the 1As. First one we have here is going to be called flecainide. This one's not only has some sodium channel activity, but also has a little bit of potassium activity as well. Again, that's going to just work to, again, further prolong that action potential even further. So you're going to see the PR, QR, SQT all get prolonged here again, right? Because remember, what is causing that repolarization of that cell towards the phase 3? It's the potassium efflux, right? So again, if I can block sodium from coming in and I can block potassium from going out, that's going to just extend that action potential even further, okay? And again, you can use this in cases like preventing things like PVCs. That's one of the big indications it was used for many years ago. So again, this could be used for, say, life-threatening ventricular arrhythmias. We'd use this for rhythm control for supraventricular arrhythmias. However, you have to be really careful on who you use this in because the narrow therapeutic index, just nature of this is the case where the right dose could help to control the arrhythmias. given slightly wrong dose and cause ventricular arrhythmias pretty significantly. And so this is one of the sets of drugs that kind of led us away from using rhythm control and using more rate control, because we had these patients who were using it for things like AFib, AFlutter. They had this program called Pill in a Pocket, where basically once you kind of knew that you were in AFib, you go ahead and just pop one of these and kind of put you back in a normal rhythm. They actually saw increased mortality. So again, that's why we're kind of moving away from these. We still use them occasionally, especially patients with congenital heart defects and things like that, but it's much more specialized as when you're going to use them. Okay, so you, from a family practice standpoint, probably aren't going to be using them too often. However, it's good to see if a patient comes in on it, you at least want to be familiar with it and know what it's going to be used for. So again, some of the things you can see with this, again, bronchospasm is kind of a unique thing you're going to see with flecainide. Seizures rarely, thrombocytopenia, and then also have this increased risk of mortality in MI. Again, could be due to arrhythmia-related issues. Not really sure on that one, but that's what we see in the literature there. And then propafenone is going to be the other 1C agent we're going to see here. This one's good because it actually has some beta blocking activity as well, so that's going to be good for kind of slowing down conduction from the atria to the ventricles. So it kind of helps with that a little bit of rate control in addition to some of that rhythm control. However, again, these are all going to be pro-arrhythmic, so you have to be really careful with these drugs here. Again, due to that beta blocking activity, that's why you see some of that bronchospasms. It kind of makes sense based off of things like non-cardioselective beta blockers, as we saw on the last test, right? And again, some blood discourages here. So these drugs don't get used too often, but at least be familiar with them, knowing which instances they may be used occasionally. Okay, so let's get into ones we're going to use a lot more frequently. Let's talk about class 2, the beta blockers. You guys know anything about beta blockers? Yes, because you did not let all that information just flit away out of your mind after the test, right? You did not dump all that stuff. It's not a binge and purge kind of class. This is a binge and just get larger and larger and larger, and all your information about all the drugs, right? You're gonna look like what's the blueberry girl from Willy Wonka? That's what you want to be, full of drug information, right? Anywho, so class 2, what are these going to do for us from an antiarrhythmic sort of standpoint, right? This is going to be good for that rate control we talked about, because it's going to slow down conduction from the atria to the ventricles, right? This probably is not going to convert someone to a normal sinus rhythm, but it's going to help to control that rhythm, to slow it down, to make sure that the ventricles can pump efficiently, okay? So it's going to decrease the automaticity, right? So it's going to slow down the heart rate. It's going to prolong the AV conduction there and decrease the phase 4 depolarization, right? So that means it's going to become more difficult to have an action potential because I'm slowing down that conduction there, right? So again, that's going to make it so that the automaticity goes down, heart rate is going to go down, okay? What is this going to do to contractility, though? It's also going to decrease that as well, right? Because we're blocking the effects of the sympathetic nervous system. Now, I'm not going to put every beta blocker up here, but I'm just going to kind of give you a few examples of ones you may be using. Obviously, propranolol being a good example of a non-selective beta blocker. Again, who you might not want to use this in? Asthmatic patients, absolutely right. But again, this is good for things like suppressing premature ventricular beats, especially if the it's kind of originating from the atria. Also, can be nice from a membrane stabilizing effect. We kind of glossed over that when we were talking about it for hypertension and for CHF, but by stabilizing the membrane a little bit, it can also help to kind of prevent some of these things like PVCs developing, help to prevent some of those arrhythmias. But again, if you have things like a supraventricular arrhythmia, right, like SVT or something, this is going to be very good to help control that rate, to slow down that conduction from atria to ventricle, to help hopefully allow the ventricles to pump more efficiently. Is this going to be good for arrhythmias that develop in the ventricles? No, this isn't really going to do anything for those. You could not use this for a ventricular arrhythmia. So a patient, has say an inferior infarct and they go into a VTAC, VFib. This is not going to be a good option for that patient, right? Because again, this is not going to do any. The issue is not with the atria conducting too frequently down to the ventricles. It's more of an issue of the arrhythmia generating in the ventricles. Okay, does that make sense? Okay, so again, good for supraventricular arrhythmias. Just like I say right here, right? Again, this can also suppress some of those ventricular ectopic beats, especially with that membrane stabilizing effect. And again, very frequently we use it in myocardial infarction, right? This is good to help kind of get the heart rate down, get the blood pressure under control. Obviously, though, you know who to be careful with this in. If they're already hypotensive, bradycardic, this is not going to be a good option for them, right? Again, we already know all the toxicity, so I don't have to go any further into detail on that. Just know that this could also come up in regards to this test, right? So again, you can't forget all these drugs. If we talk about them in a specific indication, you still got to know about them, right? Metoprolol is a good example of a cardioselective beta blocker. Again, less bronchospasm. We're going to see this used a lot more in CHF because we know it has mortality benefits to it. And actually, another good example of a beta-1 selective agent we'll use frequently, especially like in the emergency room setting or ICU, is one called esmolol. right? Breville block is the brand name, and it's nice because it's very short acting, and I can give it via continuous infusion. So that way, if I see the patient is, having, the heart rate's getting too high, I can just up the dose a little bit. It should come back down. If the heart rate gets too low, blood pressure gets too low, I can just decrease the dose a little bit. And it's very fast acting, so it's nice because I can titrate it very quickly, as opposed to something more long acting like propranolol or metoprolol. Okay, so getting into class 3 now, we talked about sodium channel blockers, we talked about the beta blockers, so you know how those are going to be working. Now we get into the class 3, and so this is going to be the ones that are potassium efflux blockers, essentially, right? So they're blocking potassium channels, they're preventing efflux of potassium here. Now notice here, they don't really do anything to that phase 0 depolarization, because they don't do anything with sodium. However, they're going to extend this repolarization period here. So what does that do to the refractory period? It's going to make it a heck of a lot longer. And so what interval in your EKG would you expect to see change? QTC is a big thing you're going to see, right? We said with the sodium channel blockers, the class 1s, you typically saw PR, QRS, QTC all prolong because you saw that the sodium channel influx, right, that first initial cause of change in that electric potential was the big thing being affected. So it's going to affect everything downstream of it. Here, we're just affecting that repolarization phase, so the main thing you're going to see is QTC prolongation, okay? And again, what's the big risk with QTC prolongation? Torsades, right? And again, especially when you're adding these on with other drugs that can cause prolongation, this is where you're going to run into big problems here, right? Anyone know what like a normal QTC is? It's a little bit different between males and females. I usually think around 440, right? 440 milliseconds is usually what I think about as being pretty normal QTC. Obviously, when you have patients that are on drugs like this, you're going to see it might get much longer. You can see, and again, I see this from a tox perspective and overdose. So if I see multiple drugs being added on, I can see 500, get up to 600 potentially. That is where you're very much at risk for torsades. You have to be very careful with those patients. But that's the big thing you're going to see. So amiodarone is probably the big workhorse class 3 antiarrhythmic you're going to see used most frequently. Okay. Now, notice here it's an analog of thyroid hormone. That's going to be important for some of the side effects we're going to see here a little bit later on. But it looks a lot like thyroid hormone. It has both oral and IV options that are available, which is nice. So again, I can use this for an emergent arrhythmia that's developing right there in the ER or the ICU. I can also transition this patient over to oral. Then it can be on it for a long period of time to help control some of these arrhythmias, right? Now, do you think this works on atrial, ventricular, both? What do you think it works on? It's going to work on any of them, right? So again, this is why we like to use amiodarone, because it's very wide, it's a lot of activity, right? So I can use it for supraventricular arrhythmias, I can use it for ventricular arrhythmias, it kind of works for anything, which is nice. So broad spectrum of activity here. But very good for recurrent VTAC. If you have, atrial fibrillations being resistant to treatment, you can try using it for this. SVT, if we have patients who are failing other more standard therapies for SVT, we can put them on this, hopefully get them back into a normal rhythm. And in fact, this is actually being used much more frequently in the cases of, if you're having cardiac arrest, especially due to MIs, we're using this much more frequently than lidocaine nowadays, right? Because again, you have less toxicity seen with it in the acute phase than you do with the lidocaine. And in fact, if you look at the ACLS guidelines, which you guys will probably get later on in your curriculum here, you're going to find that it used to be either use lidocaine or amiodarone or lidocaine. Nowadays, it just says amiodarone. It's really the thing that they recommend from the AHA. Anyway, so the other activities this is going to have, it's going to block those potassium channels. That's the main mechanism here. It's going to also have a little bit of activity in inactivated sodium channels, kind of a little bit of calcium channel blockade, a little bit of blocking alpha and beta receptors. So you're going to find there's some ancillary effects here. You're going to see there's a little bit of bradycardia associated with it, some hypotension associated with it, especially when the doses get a little too high. But the big thing here is going to be decreasing the automaticity, decreasing conduction there, and it can help to prolong that refractory period. This is why we like it. This is why it's going to have most of its activity as an antiarrhythmic. However, the toxicity can be pretty significant, especially the longer the patient's on it, the more likely you are to see this. It's a very, very long half-life, 50 some odd days in some cases, could be even longer potentially. And so again, it's going to take a long time to get to that steady state. What if I have a patient who's having a ventricular arrhythmia right now that's not compatible with life? What do I do? Yes, you give a loading dose, right? You give a big bolus dose up front to try to get them to the steady state faster. So if you ever see this, if you look at the dosing for amiodarone, you typically, when a patient's in a life-threatening arrhythmia, you give them a big bolus dose up front, and then you can put them on, say, a drip afterwards, a continuous infusion afterwards, and then transition them to more intermittent therapy. But the bolus dose is really, really important, that loading dose, because that gets us to steady state sooner. So the things you're going to see, and some of these are going to be much more chronic, you're going to see this over months to years of therapy, are going to be things like this pneumonitis and eventual pulmonary fibrosis. This can be potentially fatal, right? Especially if you have patients who have other things that are kind of degenerating the lungs over time, like smoking and whatnot. Again, you have to watch out for that. You can see things like muscle weakness, ataxia. One interesting thing here is you actually have this blue-gray skin discoloration that occurs here. So again, you have this kind of graying of the skin. You may think, is the patient just getting older and they kind of look like that? Some of it can be related back to that amiodarone, right? Things like corneal deposits. Now, the other big thing to note here as well is the thyroid abnormalities. We said it's an analog of thyroid hormone, and so it's interesting because if you had too much thyroid hormone activity, what does that do to your TSH levels? It actually decreases it, right? Because again, it's a negative feedback loop. So it doesn't act as a thyroid hormone. So in those cases, it can cause hypothyroidism, or in some cases, it actually cause hyperthyroidism. It has a little bit of activity, it can actually stimulate some of those receptors. And so again, depending on the case, you may find that some patients who have hypothyroidism may be worsened. Patients have hyperthyroidism could be worsened, or it could be somewhere in between, right? So you may have to adjust things like Synthroid doses in order to get around that. Other interactions, notice here it's going to have a lot of inhibition of things like 2C9, which is, anyone know what drug was affected by 2C9 we talked about recently? Yeah, so Bactrim inhibits at 2C9, but the other drug that is a substrate, it's really important, is warfarin, right? So again, warfarin is a big thing that will interact here. And again, patients who have AFib, who maybe need amiodarone for some rhythm control there, what else might they be on for the AFib? Warfarin, right? So again, you can see how this interaction can be playing a role here. You have to monitor the INR and make sure you're adjusting the doses appropriately. 3A4 is another big one. Again, it's not a major inhibitor of there, but again, you do have to watch those levels and watch for those interactions. Another one that fits in the class 3 category is kind of a newer one called dofetilide or ticasin. This one's just a pure, potent potassium channel blocker here. Again, this helps to maintain normal rhythm in atrial fibrillation. And actually, this is another one that has a RIMS program. Remember the last RIMS program we talked about? I mean, Accutane, right? Remember that? We talked about Accutane. You had to have patients who are in a special program that the provider, the pharmacist, the patient also be registered. This is something similar where you have to have special training to even utilize the drug because the risk of putting a patient at torsades and killing them is so high. You have to be really, really careful when you're using this. Again, unless you're working in a cardiology office, you may not be the person prescribing this, but when your patients come in on it, or they come in with torsades into the ER, you need to be able to look at that med profile and be like, okay, what's the causative agent here? But, oh, they're on dofetilide, right? And again, you have to watch for their electrolytes, right? If I'm messing up potassium levels, magnesium levels, calcium levels, any of these things can change that EKG to a point where that patient's a bigger risk for having torsades. So again, anytime you're dealing with a patient who's going to be on something like dofetilide, you have to make sure you're checking things. All right, and again, how do I check my electrolytes? What do I get? What do I order? BMP, right? BMP is going to help me out and figure that out, right? Now, do BMPs normally contain things like magnesium? Not normally, right? So again, consider what you're ordering. If you order a CMP, a complete metabolic profile, that will have all that stuff on there. But just a BMP, that's just a Chem 7, that's not going to have things like calcium. It's not necessarily going to have things like magnesium on there, okay? Chem 7, though, doesn't contain what? No, Chem 7 doesn't contain liver enzyme. That's be on the CMP, right? So it contains sodium. Also, what's below sodium? Potassium. That's a big thing you have to watch for, right? So again, it's the most important thing to watch for with these because again, it's a potassium channel blocker. So again, torsades is going to be a big risk here. Watch for that QT prolongation. You're going to be monitoring these patients. Usually, you're going to start them in the hospital and see how they're going to respond to it before you discharge them out on this medication, right? And again, it's eliminated in the kidneys. So if you have someone with poor kidney function, guess what? They're going to hold on to the drug and be at even more risk for this. Again, this is a big, dangerous drug, but can be very effective. Another one that kind of fits into the third class 3 category here is sotalol. You may be thinking, wait a second, what's sotalol? It's a beta blocker. It should fit in class 2. But guess what? Sotalol was that one notable exception here. It actually has some potassium channel blocking effects as well. So, if you have a case where I need to use a beta blocker for a patient for like hypertension, sotalol is not going to be the one for that. However, someone who has like a history of AFib, this may be a good option for them, right? Because again, it's going to work kind of like amiodarone does, but has that additional beta blocking activity as well. So it can be very useful from that situation. But it can also be used for ventricular arrhythmias. We said normally beta blockers can't be used for ventricular arrhythmias. This is an exception where that could be used, right? Again, obviously we have the same beta blocking toxicities we would normally see with a beta blocker, but with the addition of torsades being a risk here because of that potassium channel blockade. Yes, ma'am.
So if this is similar to amiodarone, and it seems like it has less side effects, why won't people just go to that one first?
Because you'll find it's probably not going to be as good for. It depends on where you work, right? So it depends on the situation you're working in. So if I was working, say, like in an electrophysiologist office, and they were dealing with these kind of patients who had maybe congenital issues like this, you may use sotalol more for, say, chronic maintenance of their rhythm, right? Trying to maintain that person in a normal sinus rhythm. That could be a good option for them. Versus if I have someone who's coming into the ER and they're in cardiac arrest and they're in VTAC, amiodarone has a proven track record. I can use that IV to get them back into a normal rhythm, hopefully. And so that's just what you use. So it depends on the setting in a lot of cases. Those patients may or may not be transitioned over to oral amiodarone for the long term. It's hard to say. A lot of it depends on what caused that arrhythmia in the first place. Was it due to an MI? Was it due to drug toxicity? Was it due to X, Y, Z? So a lot of it depends. But you're right. Yeah, it seems like, this seems like it'd be preferred. In some cases, it will be. And again, I can only speak to my perspective, which again is mostly pediatrics, emergency medicine, toxicology. So again, if you talk to someone else who has a different perspective, they may have a totally different opinion, right? So the last group we have here is going to be our class 4 antiarrhythmics. This is going to be our calcium channel blockers, namely which ones? Which ones affected the heart? Non-DHPs, right? Which includes verapamil, diltiazem, right? Those are the two big ones that are going to fit into this category. The dihydropyridines are not going to be working as an antiarrhythmic drug, right? If anything, they can worsen arrhythmias by causing reflex tachycardia, right? But again, it's going to be a negative inotrope, slows down AV conduction. Oftentimes, you're going to see this being used as an alternative, maybe if you can't use a beta blocker to help control some of these atrial arrhythmias or these supraventricular arrhythmias that are developing. So again, they're both going to be working on these calcium channels. It's going to help to prolong that refractory period. And again, they're going to be more effective in very active tissue, right? Because again, what's causing that muscle to contract? A lot of calcium being released from the sarcoplasmic reticulum. What causes that calcium to be released? Calcium influx. And if you remember, where does calcium influx work on that action potential we saw? So remember, you saw that initial upswing is going to be due to sodium. You see that little tick down, and then you see that plateau phase. That's calcium influx right there, right? And then potassium efflux out. So again, that plateau phase is where calcium is playing a big role there. So again, if I can decrease calcium influx, it's going to decrease. And again, the more active the tissue is, the more likely you are to be seeing that calcium influx. So again, that's why it's more effective there. But slowing down conduction, suppressing the SA node, AV node, decreasing contractility as well. Okay. So you already know a lot about these. I see these used most frequently for things like, supraventricular tachycardias, or maybe are unresponsive to other drugs. We'll talk about one we use very frequently for that later on. AFib's another big one as well. And again, we already know the toxicities here. We know the drug interactions. Remember which enzyme they inhibit? 3A4, remember? Verapamil, diltiazem, they inhibit CYP3A4. That was a big thing we talked about. And I know that was a test question, right? Which hopefully everyone got right. So getting into some miscellaneous agents here, we're going to have 3 we talk about, adenosine, digoxin, sometimes called digitalis, just depends on the nomenclature, and then magnesium. We'll talk about some indications for those. Adenosine, anyone know what we use adenosine for? Stop the heart, right? Temporarily, right? Not permanently. So adenosine is going to be good for kind of a very short kind of reset of the heart when you have patients who have supraventricular tachycardia, right? So they're coming in for SVT, heart rate's just kind of just going crazy. This is going to help to kind of reset things very quickly. Kind of stops the heart because adenosine is kind of like putting on the emergency brakes on the system, right? So again, you can think about it kind of working the brain to kind of stop seizures potentially. But the big thing we think about from the heart is it's going to stop the heart, and then it gets metabolized very quickly, goes away, and then the heart starts up again, hopefully, right back into a normal rhythm. It's a very short half-life, only 2 to 3 seconds or so. So that means you have to give it very quickly. Okay, and the biggest thing I will see is that patients or people do not give this drug correctly, which makes the first dose not work, and they think, okay, well, I need to give more, when really they just probably didn't give it correctly. So the way they do that is basically we're going to use a 3-way stopcock. Right, so you're going to basically have one end connected to the patient. You're going to have one end with your drug and a syringe, and you're going to have the other end connected to a saline flush. Now, again, when you have a patient comes into the ER, they have a nice, perfect central line you can infuse into. No, they're going to have a peripheral IV, probably in the AC, and so you need to make sure you have to get that drug from the AC to the heart, right? So again, that 10 seconds may be gone by, half your drug's already gone. So you have to make sure you're pushing it very quickly. So I will make sure they push the adenosine very quickly, and then the saline flush has to go right afterwards to try to get it to the heart as soon as you can. By doing that, you're hopefully going to get as much drug as you can there. It's going to help stop the heart for a second, and then hopefully it goes back into a normal sinus rhythm.
So what we did, we used to take the lock.
Mm-hmm.
The lock holds around 2 mL. So we would put the adenosine in the lock.
Okay.
And flush it behind it. That way you get the drug and the flush.
There you go. Yeah, so there's there'll always be multiple ways to skin a cat. So yeah, so if that method worked effectively for you, then I'd say, hey, go for it. But yeah, you'll find little tricks and things like that. It's just what we did at Nemours, when we were dealing with our patients there. So it just depends. Yeah. Anyway, so very good for these cases here. A lot of flushing you can see with this can cause kind of some vasodilation, but again, it's very short acting, so you're going to find it's going to be very intense flushing, some shortness of breath, it's burning in the chest, and then it should go away as the drug gets dissipated there. Digoxin we know is going to be good for which indication do we talk about? Usually for heart failure, right? We talked about those neurohormonal effects. We talked about it's good for contractility standpoint. Again, this is also good if you had a patient maybe had CHF and also AFib. This could be a good drug for them, right? Because this can help with the contractility, but it also can kind of help to change the automaticity, kind of work from that standpoint. So you can kind of pull some double duty there. However, I will tell you that digoxin gets used less frequently nowadays, mainly because of the toxicity profile, right? Mainly because of the narrow therapeutic index. You have to monitor drug levels. It's really eliminated, so you have to adjust for that. So it can be a very dangerous drug, but can be effective in the right kind of patient. Again, it's good for slowing down that ventricular heart rate, so good for more kind of atrial sort of arrhythmias like AFib, aflutter. However, be aware that it can induce things like heart block, right? Because it has those kind of bradycardic sort of inducing effects there. And we talked about the side effects, so you don't need to worry about, or we need to worry about that, but I'm not going to reiterate here because you already know about a lot of the side effects. And remember kind of the unique one you saw? Not blue. The yellowing of the vision, right? What do you call that? Xanthopsia, right? It's kind of yellow-green halos around lights and stuff.
I heard that. Like Van Gogh painted Starry Night on digoxin. Is that true?
I don't know.
Yeah, I've heard that from like multiple sources.
Multiple sources that were there at the time, or
Yeah.
witness account? Interesting, very good, huh?
But yeah, I heard that, like you painted Starry, because it's all like blue.
Yeah, there could have been a lot of like absinthe involved, and who knows? I mean, yeah, it could have been a lot of things there. There you go. Yeah, so you think Starry Night, think Van Gogh, think digoxin, go for it. Yeah, well, yellow halos around all the little stars, that could work for sure. Listen, if it's stupid and it works, it ain't stupid, is what I would say. Which I'm not saying that's stupid. I'm just trying to say that whatever helps you to remember something, hey, go with it, is what I say, right? Don't take offense to that, but that's just a common thing where it's just like, if it's stupid and it works, it ain't stupid. Is what we're trying to say. Anywho, don't put that on my eval, please. No. So the last thing here, the last kind of miscellaneous agent is called magnesium. Again, this is just a normal electrolyte that your body contains anywhere. And so we use this for several cases. We can use this for things like preeclampsia in pregnant patients. You can use this obviously for things like asthma. We talked about briefly, I believe. We can give this to help kind of work as a bronchodilator. But the big thing here, it works on torsades, right? So if you think about the drug of choice for torsades, magnesium is going to be the case here, right? So that's going to be an ACLS. It's going to be on your boards probably. Just be aware, though, that you can see a lot of flushing. You can see some hypotension with this. So you probably want to get some fluids along with it to avoid bottoming out the patient's blood pressure, okay? And again, we have things like built into place so where we have a doc who's ordering or provider who's ordering a magnesium bolus. We automatically link it to a bolus of saline to go along with it. So that way we know that flushing is going to occur. Let's make sure we give some fluids to help prevent that, right? They can opt to not use it if they want to, but we kind of try to automate a lot of that stuff to make sure the patient gets what they need. Okay, so any questions on that? Yes, sir.
So the mag, we never really figured out who really works. You doesn't live, we never put this on.
So it depends on how stable the patient is, right? So again, if they are coding actively, if they're hypotensive, we may just go ahead and just push it, right? Just push 2 grams. If they are more stable, then yeah, I would recommend diluting it so that way you can kind of infuse it in a little bit slower. It's not going to kind of cause as much of that kind of profound vasodilation, so that's typically what we do. But again, torsades is not something you see very frequently, but when you run into it, you want to know what to do, right then. So, okay, let's do 10 minutes, and then we'll come back and start hitting up our GI stuff.